afternoon. Welcome to our next episode of BurnCast. My name is Cindy Colson, and I'm the Injury Prevention, Education, and Outreach Coordinator with Trauma and Burn Surgery. And I am accompanied by Anne.
Hi, I'm Anne Ciriello. I'm one of the trauma and burn nurse practitioners.
And our special guest today is Dr. Bird, and we've had him on our BurnCast before, but whenever Dr. Bird comes to our BurnCast, we change the name to a BirdCast. Dr. Bird, do you want to explain to us what your role is in for burns?
Yeah, so I am the chief of trauma and burn surgery here at Children's National Medical Center, and the long and short of what that means is that I have a great team of nurse practitioners and social workers and therapists and nurses, and we together take care of the burn patients at Children's National. And so always delighted to join the BurnCast and to let you know my thoughts on a few things.
Great. So we've been doing the BurnCast for a while, and we haven't really done anything that was like very basic about like what a burn injury is. So I'd like to start out with you like defining for us like what a burn is, what a burn injury is, and go into like the burning process of like when it starts, when it stops, and just like a quick overview of that.
Yeah, so the most common burns that we see in kids are spill scalds, as many of you know who have taken care of our patients. But we see other mechanisms of heating, direct contact on objects, or spilled grease or food, or a variety of different things. Basically, some hot something gets on the skin. And that burning injury starts immediately, and depending on the thickness of the skin, what part of the body, and how old the patient is, and the thickness of the skin, that injury can be almost instantaneous. The burn, the hot liquid or the hot substance contacts the skin, and you can remove it immediately, and the burn is done. And the burn depth can be anywhere into the epidermis, which is like a sunburn style burn. It can be into the dermis, which is that layer of skin where new skin grows from, or it can be all the way through the dermis into the fat that's underneath the dermis, and have a full thickness injury. And when the burning element is on there, sometimes, if you have if this happens to you at home, you have a kitchen burn, and you get some hot liquid on your hand, if you can immediately get under hot water, your hand under cold water, you can change the depth of that injury. So you can change it if the burn is more superficial. If the hot element is just hot enough and the skin is thin enough, there's nothing you can do. It's a done deal. And then what we see, so that's the immediate burning part of it. But then what happens is the burn injury then goes through a period of evolution. And so typically when we see those patients in the emergency department, we'll see generally a blistered area. Sometimes the blisters will have kind of gotten scraped off in the course of whatever kind of care the parents provided, or just from friction from clothes. But we'll see sort of a blistered area. And we routinely, for anything but the most minor burns, will clean up that blistered area to get a sense of what the underlying tissue looks like. And at that point, we make an initial assessment of what's going to happen with this burn injury, and an assessment of how deep it is. Sometimes it's pretty obvious that the burn is deep. A patient comes in with a flame burn, and the skin is leathery. We know it's a done deal. It's a deep burn, and we just need to be managing it that way. Other patients, and this is actually the vast majority of our patients, is that we can't really tell what's going to happen at that initial presentation. So you get rid of the blisters, you clean things up, and you take a look at that burn, and you're just not certain where that's going. And that's where we put the patients into an observation phase. And do you want to add something on top of that?
No, I think that was all really good. I agree. In the beginning, it's really hard to tell the difference in the depth. Sometimes, if it's not this done deal that Dr. Bird's talking about, when it's a very deep, leathery flame burn, a lot of these spill scalds are hard to tell what the evolution of the burn is going to be. So there's sometimes a few little hints in the burn itself, but a lot of times you're looking at a pink, moist wound that could look very different a few days later.
So when does the evolution of how deep a burn injury, like how do you know like when you'll know like the final depth of a burn? Like how long does that take?
Well, let me sort of give you a non-answer here, is that we know how deep the burn is based on the ultimate behavior of the healing of that burn. And so, I mean, I basically just restated your question, but let me just tell you why I said it that way. Is if we were to take every burn that we have and just simply observe it and do dressing changes and see what happens over time, we would become very, very smart day by day of what that burn depth is. And so we generally think that if a burn doesn't heal within 21 days, that burn has a high likelihood of forming scar and having long-term pain or functional limitations if it's in the right area of the body. So eventually, if you were to simply leave a burn and do dressing changes on it, you would eventually know how deep that burn is. It would be pretty unambiguous. And so get back to your question is when is that point where we know that when do we know what the future will be? And that's where this becomes an art, not a science. And so this is where me and our very experienced nurse practitioner team will look at the burn injury, and based on our experience seeing many burns and seeing how they evolve, we'll make a judgment if this is a burn that we still aren't sure about, we need to watch longer. This is a burn that we used to be uncertain about, but now we're certain that this is superficial, or we're now certain that this burn is deep. And then we need to change our algorithm for treatment based on what that is. There's some technologies that are being evaluated for evaluating depth of injury. These are laser technologies and other things that in ultrasound technologies and other things that have been looked at to see if we can use some objective tool to look at burn depth. Unfortunately, these technologies aren't ready for prime time. They're still, I believe, I don't really know that anybody is using these in standard clinical practice. They're usually done in the context of research protocol. Hopefully we'll one day have these, so we don't need to be relying on our judgment, but still relying on a machine that tells us this burn is not going to be healed in 3 weeks, or this burn is not going to be healed in 6 weeks, or this burn, don't worry about this burn, this one will be fine. But right now we have to rely on our judgment. It's a day-to-day thing, and that's why some patients when we believe that we can leapfrog their burn assessment, their burn depth assessment forward a few days, we'll put them in a dressing that we don't have to change for several days. But for patients with large burns that are indeterminate, we look at that burn wound every day, because every day we get new information that helps us to be smarter about what direction that the injury is going.
What would you say the most tenuous time period of a burn injury is? Like, what's the and that would be like looking at it, re-looking at it, the care around the patient during those times. Like, what are the most important days? Like, we know that all days are important in taking care of all of our patients, but what are like the most critical?
Yeah, I think as far as, and let me just answer your question in the context of burn depth assessment, which is what we've been talking about here today. It's really the first 1 to 5 days, maybe extending a little past that. Those are the days where if we have a burn that's indeterminate, that we really need to be making decisions. And part of the reasons that we need to be making decisions in these early days is that we really want to move the patient's care forward. And we can't just say to a family that, listen, no, we're not certain where this is going. And so we're going to commit you to 3 weeks, 5 weeks of daily dressing changes and tell you we're going to get a little smarter every day. We need to move forward with the patient's care. So usually within a handful of days, and I'll be a little vague about it by saying a handful of days, usually in a handful of days, we have a good sense of what the direction is going, and can help direct that patient's care with that initial information. And do you have anything to add?
No, it's funny you say handful, because when Cindy first asked, I was like, thinking in my head, it's a handful of days, like less than a week, but something in it's the first group of days. I think the other thing that I would add to that is that burns are often annoyingly heterogeneous, in that there are many different depths of burn injury, like the whatever, if we're talking about a spill scalds, because that's what we mostly see, where it hits first is usually the hottest, or if it pools in a fat neck roll, it gets a little bit deeper there. So there's these areas where some parts are deeper than others, and you have to cater your treatment to making sure you're taking care of the deepest parts of the burn, but you're also taking care of the patient and what they can tolerate for dressing changes, that you're really oftentimes trying to put on a bandage that covers everything, but you may have different depths of burn injury right next to each other and kind of fading different depths of burn injury.
Yeah, this is actually a pretty common problem that Ann brought up, and it's a fair amount. This is where the art, the dressing application and choice of dressing is an art, not a science. So not only do you have this problem of burn depth assessment, which I explained, it's really not a, it's not a, it's sometimes very difficult. But then you're dealing with a burn that has obvious differences in depth, and so you have to look at this injury, and it's like some dressings would be perfect for this part of the burn that's very, very superficial, and then some areas are deep and really need this more focused management strategy. And so what you can't do is make the patient sort of mosaic of different treatments. We sometimes mix and match areas, like the face will have one depth and the chest will have another depth. But what do you do if the chest has 3 different depths? Like, what do you do? And so we often will have discussions about what the best strategy is, but in general, if you're going to put one thing on one area that has mixed depth, you go for the worst depth is kind of the strategy. But in general, the burn wound management strategies for deeper burns are more complicated, more painful, and for superficial burns are less. So this is a conflict of how do you manage these mixed depth areas, and it may be in an area that's relatively small. It may be an area that is just 10 by 10 centimeters, or 5 by 5 inches, that has mixed depth in it, and you have to make a decision about what's the best overall management for that one focus area.
Yeah, the example there is that sometimes if you have a very large burn and you have this deeper section, you think that you put the patient in a long-acting dressing to hope to heal as much as you can, so that then you can address the deeper part later, especially if you don't think that the patient would tolerate dressing changes, or they can go home if they have the long-acting one. So there's a lot of different variables that go into choosing treatments for burn injuries.
And I think probably the scenario that we see most often, so toddler spilled scalds is the number one burn profile of patients who are admitted to the burn service. Is by far the number one group. And so these patients typically will have very deep area to the shoulder, and they'll have sort of the area on their chest will sort of at the top of the chest be deeper, and at the bottom of the chest be less deep. And it's sort of like candle, like wax going down the side of a candle. The hottest area hits the shoulder, and then as it rolls down, it becomes the liquid becomes less hot, and the burn depth becomes less deep. And so this is a very common scenario. So we have a kid who's got, say, a 10 to 15% spill scald. They'll get a deep burn of their chin and their shoulder, and then the rest of the burn will be less deep. And then we have to have a strategy that we can do that makes sense. And when we're sending a patient home, we can't send patients home with very, super complicated dressings. And when we have our nursing team help out on the floor with the dressings, it's difficult to say, put a little bit here, put a little bit there. You have to come up with something that works for patches of area. And we see this mixed heterogeneous burn distribution depth. We see this all the time, very common.
Yeah, burns are tricky because from everything that you're saying today, no burn is the same. They can be similar. No child is the same. They can be similar. No injury is the same, but they can be similar. And some dressings work for some parts, but one burn can be different in multiple areas and in different parts of the body. So there really isn't anything that's consistent, other than we have to do the best we can with what we are seeing on a daily basis, and that can change every single day.
And I can tell
And
you,
you also, you also have to take into consideration the family a social and home environment as to what families are capable of doing or changing, and whether or not the patient is sick, eating, has a fever, ready to go home. Like there's also all the patient variables in addition to the skin and wound healing itself.
Well, right, and you were saying like the healing process is affected by so many different things. So with all of our toddlers that come in, they have rhinoentero. Are they going to heal the same as a kid without rhinoentero?
Well, and one of the and as Anna was alluding to is that we sometimes make choices about what to do based on a compromise between what the perfect what we would want to do for wound management and what is feasible to do for wound management. So, for example, if we have a patient who's critically ill in the ICU with a fairly large burn and we need to do a quick dressing change, we're going to cover everything up with a single dressing and get it done as quickly and efficiently as possible. If we have another scenario, would be we have a kid who has multiple areas that are different depths in the same area of the body. But the family is not a family that can do daily topical dressing changes. But we believe daily topical dressings are really the ideal dressing for that kid. We may put that patient in a long-acting dressing, knowing that there's deeper areas that are not ideally treated with that long-acting dressing, because we need something that's feasible for the family to have. And this is a strategy that we, even this week, have had patients where, we've made a compromise for the social circumstances of the family and the parents' ability to manage their dressing. We've made compromises to find the best strategy that deals with what we're confronted with, so we can move the patient's care along, which is not just the burn care, but getting the kid back integrated into normal life, eating and doing all their normal activities. And let me just, even this week, the burn depth changes quickly. And so, and can probably give a quick example too, but let me give you a quick example of this. I saw a patient that earlier this week that clearly had a deep injury and looked like it was a large enough area that warranted grafting. So I brought the patient to the operating room with the operating room all set up to be for the patient to be grafted. And then when I took the dressings down, the patient's wounds had evolved even in the short time from the day before, that it became clear that the amount of area that would be grafted, it was so small that it wasn't worth proceeding. And I just basically redid the dressing change and didn't proceed with surgery. So many of you see the patients scheduled for skin grafting and they go down and then they come back with just a dressing change. Well, that's what happens, is that it's not that we didn't know what we're doing, or we had misinformation or something. Is that literally the burn wound changed and evolved in the short time span from the time that we made the decision to go to the operating room the day before and the time that the patient's in the operating room, where we're making a decision about whether or not to proceed with skin grafting. And you probably have similar stories about where that we've made a change, I guess, midstream.
Yeah, I think it happens all the time. I mean, I think you see a burn that you initially looks like it might not evolve to be deeper, and you put in a long-acting dressing and then when you take it off, it's much deeper, or you thought that it was going to be kind of more of like a superficial second degree, and it looks like it's a deeper second degree, and that is sometimes predictable and sometimes completely unpredictable in what the results are that you get.
So tell me, and either one of you can answer this question, but tell me how you prepare as a provider before you take off a dressing of any burn patient, whether it's in the OR, in the floor, in the ICU, because since you don't exactly know what you're going to get when you unwrap the dressing, you have an idea, but it might change. What do you do? Do you bring something different? Do you order something different? How do you prepare to be I think this color might be purple, but if I unwrap it and it's bright orange, I have to deal with this. How do you prepare for that? And how do you prepare the team that you're working with for that?
I would group some of those together. So I would group my floor patients and my clinic patients in a bit of a similar manner, because they're less likely to be sedated. So when I take that into consideration, I'm taking into consideration the fact that I'm working with an awake child who has to deal with this burn dressing. So as soon as I open the burn, burns are more sensitive when they're open to air. So I try to go in with everything that I think I might need without
what are
being
those
too
things, like
wasteful. Yeah.
dressings?
So that would be dressings in closed packages. If I think that a dressing is definitely going to be used, I'll open it up and prepare it. If it takes a couple steps to prepare, that also, unfortunately, if it's a medication, means medications from pharmacies. So sometimes if we might need a daily dressing or a long-acting dressing and you don't know until you see it, I'll bring them all in, because it's not fair to the patient to have to wait for me to go back to my computer, order medication from pharmacy, call pharmacy, pick up the medication, come back from pharmacy. That can take 20 minutes or more. It can take 45. And that's not fair to the patient. And then you have to put the medication on a bandage, something like Silvadene, sulfamylon, bacitracin, a number of different things that are supplied by pharmacy. So I will often order medications and also bring in long acting, and then make the decision depending on what we see. I try to prepare people. I try and prepare parents in clinic. I say, I brought in a couple of different bandages. I think I know what I need, but I am not always right on my guess, or burns are very dynamic. So if I need something else, I'm going to step out of the room and I'm going to go grab it. And I try and also prepare people on the floor as well, nurses, families. If I'm not preparing you, please tell me. I'm happy to discuss what decisions I'm making and why I'm asking for all these things. I'm not trying to be excessive or wasteful. I think we try and do something similar in the operating room or in the ICU. We sometimes have a little bit more time we always want to be prepared, but we sometimes have a little bit more time to make those decisions. It's not as traumatic for the patient if you're looking at it from that standpoint, but it's a number of resources of people who are waiting, and the anesthesia time or sedation time with the PICU or the OR as well.
Yeah, and I want to emphasize something that Ann brought up is that the majority of people who are watching this BurnCast will see the patients we're taking care of on the floor, and on the floor and in the clinic. These patients are they have maybe oxycodone, or they'll have or sometimes intravenous narcotic. But these aren't full sedated patients, and so it's in our best interest to move things along. And so anything that can be done to move that dressing change along, to make it happen faster. We don't want to scare the family. You don't want to be sloppy. I mean, that's not what I mean by moving things along. But what we don't want to do is to have a scenario where we're having some detailed discussion or looking for supplies, or sort of like leisurely changing the dressing. It's really in the best interest of the kid is to be prepared, be decisive when we're taking the burn dressing off and cleaning the burn wound, and being decisive in putting dressing back on. And I use that word decisive because the hesitancy, being kind of poking around with things and being hesitant and being not prepared, those are the things that make the dressing times longer. And a longer dressing time is just, as Ann said, it's the longer time that the burn wound is exposed, the more painful. You get the burn dressing on, and basically the amount of discomfort markedly decreases. And so that's what we're looking for. We want to make that time as short as possible.
So you're doing everything you can to bring anything that the burn could be dressed in when you open up that dressing.
Yeah, exactly. And I think it's confusing sometimes for people who, we take a lot of things for granted because we do this every single day. But I think it's confusing for people who see that we're doing this, like, we're doing a dressing change in our initial plan. We have to change, or we need to get, more supplies for something if we didn't think it is, like we're totally off base on thing. Or, we do one dressing change today, and then tomorrow we're doing a completely different dressing. We have topical dressing today, and tomorrow it's not a topical. And then, boy, guess what? The next day it's a topical dressing instead of a long-acting dressing. And this has to do with, it's a lot of different factors. It's this burn wound that's evolving. It's the patient's, the medical, the basic setting of the patient is evolving. We may have a better sense of what the parents can't do. We may have, the patient may have some medical issue that really steers us into a different choice of what we want to do. We may be thinking about the resources that we have available to do the dressing change. So typically the reality is that we're a 24/7, 365 hospital, but we recognize that we don't have complete full staff on the weekends. So when the weekends come, we have to think: is this a dressing that is something that's going to be manageable for everybody over the weekend, or is it something that we can without compromising the care of the patient, put a dressing that can last longer, and so the patient has less dressing changes than we would choose otherwise. And that's why I think that it's an outside observer. You're saying, well, you're doing one thing on the face and another thing on the hand, and then the next day you're scrambling it again. Well, that's why there's all these factors are playing into us making those different choices each day.
So I think that, I never even asked the question that I wanted to for this BurnCast, and that is, why do we have so many different dressings on every single day? Like, why does it change all the time? But I don't even feel like I need to ask that question, because both you, Dr. Bird, and Ann, have really explained the dynamic process of the burn and how it changes every day. And that's why different dressings are used in different areas sometimes and can often change day by day. Ann, could you talk briefly about just again, like, to reiterate, the ordering of different things that have to come from the pharmacy, and just because you order it doesn't necessarily mean that you're going to use it?
Yeah. So medications come from pharmacy. I would say the most frequent ones, and that includes like ointments and creams and topicals. That I would say the most frequent ones that we use for burn care at Children's National are Silvadene, Sulfamylon, Bacitracin. We also use Vash, which is a topical cleaning solution. So that comes from pharmacy. Aquaphor is something we use very, very frequently, and again, comes from pharmacy. So any of those medications need an order, and that has to come from the pharmacy. So you have to have a fair amount of time, versus something like a long acting or a gauze wrap, a burn shirt, Acticoat, Mepilex AG, or silver impregnated long acting bandages, as well as Xeroform, which is an antibiotic impregnated gauze bandage. Those all come from the storage room. So I can walk into a closet, grab those, and come right out and have them. If I'm in the middle of a dressing change, I can go grab one of those if I have to, and be back in 30 seconds, depending on where I am in the hospital. So those are a lot easier to come by in a more timely fashion. If we don't use medications and they are unopened, they can be returned to pharmacy. So we do take that in mind. But because it takes a lot longer to get medications from pharmacy, I will often order a daily one of those topicals if I think it's possible, that I will need it, because I'd rather have it and return it to pharmacy than have the patient wait for it or not get it when I think that they truly need it, because of the amount of time it would take to get it.
Absolutely.
Did that answer your question?
It did. Ann, can you tell me, do these medications, as you order them from the pharmacy, do they show up on the MAR?
Yes, they are signed off on the MAR. We write anything, all of the ones that I mentioned that comes from pharmacy, we will write them as either daily, twice a day, maybe twice a day, and then a second one as needed if you're using Aquaphor multiple times. But those will be ordered with a frequency and are signed off by our nursing staff on the MAR.
When you order them, in the just in case,
Mm-hmm.
do you order them on like hold, or do you have to put in how, like, because if you order it as a just in case, and so that doesn't mean you actually want the bedside nurse to put said ointment on the burn, like, how do you delineate that in the MAR?
Yes. So if I think that it's very likely that the patient is going to use it, and I'm almost certain that I'm going to put it on, or then I will order it as daily and know that in the future, kind of going forward, it'll be a daily thing. And then the nurse will record it once will mark it as administered once we've put it on the patient. If I think that it's a possibility, I'll sometimes order it on call and then write in a comment to have it bedside for dressing change on this date, so that it doesn't show up as something that has to be administered. Sometimes I order it as daily and then we don't end up using it, and then it can be charted as not done. And I believe that there's like a comment to say plan changed, or whatever it is when you're marking it as not done on the MAR.
Okay, cool. I think this was really helpful of explaining like why we have so many different dressings, because we do change the plan a lot, but it's not because we have ADHD. We are changing.
Well, we might have ADHD, but that's not the reason why we're changing the burn dressing.
We're changing the burn dressing because the burns are dynamic, therefore our care has to be dynamic.
Can I just make one more final comment, is that, as I said before, the dressing changes is an art, not a science. And we notice is that as a group, we sort of follow each other's practices on what we choose for dressings. And so if we have a strategy that particularly works, then we kind of go with it. And we go with it. And we have different kind of strategies that we might choose. Like, this is a good outpatient burn strategy for this kind of burn, and this is a good inpatient burn management strategy, or this kind of dressing is good for inpatient burn. And we all sort of, since we meet so often and work together so closely, we will basically follow the same lines. Now, all that being said, there are some nuances around the edges that some of us have certain preferences. Like, we know if Anne's in clinic and she's confronted with this kind of burn, she will choose this strategy. We just know. And then another one of her colleagues or me, I'll choose another strategy. She knows like what I will bias towards. And so a lot of our discussion is negotiating about what we believe is the best compromise between our personal interests. And so a lot of what you're seeing, we try not to change day to day based on provider preference. We really try hard not to, especially in an inpatient setting, that we really try hard. It confuses the nurses, it confuses the families, and it confuses ourselves, I guess, in the end. So we try to be consistent. But that's part of it too, is that we just have different viewpoints about how things are managed.
Yeah, and I will say, kind of on a similar thought of it's an art, not a science. When I'm in clinic, if I think, I will often on an older patient give them the option between a daily and a long-acting dressing if it doesn't impact the burn healing. So I will say, if I think one or the other is necessary, I will absolutely tell you and I will make that treatment decision. But if I have an option between the two, would you rather get in the shower, clean your burn every day, or would you rather do some armpit cleaning for the next 5 to 7 days and take a long-acting dressing? And sometimes patients don't care, sometimes families don't care, but sometimes the patients are like, I have to shower every day, or I do not want to see this burn for another 5 days. And if that's the case, then I let them be part of that decision making as well. So there's, that's a clinic thing. So that's not necessarily what people are dealing with inpatient, but that speaks a little bit to all of the many factors that go into this, that it is, sometimes it makes a big difference and there is truly a scientific reason for the one that we're choosing, but sometimes there's some nuances there that there might not be one perfectly correct answer. There may be a number of different answers, and we try as a team to stick on the one that's best for all of the number of varying factors that go into play.
And even in the last couple of weeks, I can think of examples where Ann and I have been together and we've talked with the family and say, you're in the hospital and we're doing dressing changes and you're going home. And do you think you can do this? Like, here are the different choices. Which of these choices do you think you can do? And then we have to make some judgment, is that, are they able to do that with the training that we get? Because we don't want to make a wrong choice. We don't want to send the patient home when the family can't be discovered after they get home that they can't do anything. They can't manage any dressing, and that's just a bounce back, and nobody's happy about that. On the other hand, we don't want to keep patients in the hospital because we can't trust the parent to move forward with the patient's care. That's no good either. So we have to, and we've had patients even recently where we have the patient set up. It's like day after day of daily dressing changes. And then we walk in, they're now 6 days, 10 days, I don't know how many days in. We walk in and say, okay, it's done. We know what this burn is doing. Like today, we finally know, and you're going home. And then it's like, wait a minute, like, how come we're making this decision all of a sudden? Well, we finally put it together. We have a strategy the family can do at home, that they're capable of doing at home. It's appropriate for what we see. We now have a clear direction of where this burn injury is going. And, this last minute decision is made because we now finally have the information to make that decision to get the patient home.
Yeah.
People see that all the time.
Yeah. And a lot of times with this classic spill scald pattern in the toddlers where there's a face or head involvement, faces are very overwhelming. They swell quickly. There are a lot of, it's painful for the parents. It's difficult for the child. So a lot of times we'll take the chest or torso burn and put it in a long acting so the family can focus just on the head and get home. And kids do better usually at home. They do better with their high chair and their sippy cup and sleeping in their own bed and eating their own food instead of being in the hospital environment. And so we may take it would be best to put the entire body into a daily dressing change, but let's get this kid home, put them into a long acting on the chest and just focus on one part of the burn, the most visible, the deepest, faces. That's what you want to really work on. And that may be the choice because that's what's best for getting the kid out of there.
So if you could think of, and Dr. Bird, I'm going to ask you first, what would be your one thing what's your take home point for nursing, about the frequent change in dressing and the frequent change of burn care because of the dynamic nature of the injury? What's your one take home?
I think it's just be prepared for it. It's part of it's the nature of the business. This is what burn care is about. It's something that's dynamic, it's changing. Just be ready for it to change. And I think if it's not changing, just be happy that you saw the same thing yesterday. But expect it to be different. Just expect it.
Anne?
I think that was really well said, and I like that one. I'm glad Dr. Bird went first. I would like to say, and I'm not sure that I completely mentioned this, that if you have questions about the things that are changing, please ask us, because we usually have a lot of we've talked about all these factors, but I am happy to discuss in my office, outside of the patient room, in front of the family, wherever you want, why we're making these decisions, what parts of the burns we're trying to, kind of what my thought process is on that. And if you're frustrated that the plan is changing, let's talk about it, because I'm happy to talk about it. Please come up to our team. We want to we don't want to make this harder for people. And we know that this is how the process is, but please, we want people to understand, and the door is always open to kind of discuss what's going on.
And I think my take home for everybody, and to remember that if you have a specific ointment or anything on your MAR, it doesn't mean that you have to give it. You're only giving it if appropriate. And it's completely fine to chart something as not done if you are not using that dressing. So it's just a good reminder of really looking at your orders and making sure that they make sense, and then following up with what Anne said. If you have a question, ask, and following up with what Dr. Bird said, be prepared for it to change. Thank you guys so much for listening. And Dr. Bird, as always, it was a joy to have you as our guest and in our BurnCast, and can't wait to see you guys next time.
All right. Thanks, guys.
Thank you.